Is it blinking? Does it look like it's recording?
Yeah, you're good.
Okay.
Can you see me? Okay. All right. I think I'm going to get started. Should I close the back door or? I will. Huh? Sure. Okay. Are you going to hang out there? Okay. Thank you.
You're
I
welcome.
did not ask you here to do that. Good morning, you all. Thank you for coming. I am excited to be here. So, why don't we just launch in? Yay, it worked. So, today, I am Dan Lewis. I am a physician. I'm semi-retired. I worked for Kaiser Permanente for over 30 years. I retired at the end of 2020. And I do a combination of medical work these days, residential addiction treatment and medication-assisted treatment. So you're probably scratching your head like, what's a medical doctor doing talking to us? And basically, what I've learned since I retired is, MD, therapist, counselor, psychologist, we're all helpers, and the clients don't care. Does that make sense? Please ask questions at any time, raise your hand, blurt it out. A couple of abbreviations I refer to: FIT, Feedback Informed Treatment, ROM, Routine Outcome Monitoring. I was fortunate to, just as I was retired from Kaiser, kind of discover this world of measuring outcomes and collecting data, and it really energized me. You can just ask my wife, who's sitting right there. She's tired of hearing me talk about it. I do have one disclosure. This was me last year. And actually, I have two disclosures. I am so glad that I don't have to be wearing a mask. So this is me speaking at your symposium last year. But my daughter is a third year in your counseling program. She's gotten pretty good at volunteering me to talk in front of your class. I wouldn't be here if it weren't for her, but of course she wouldn't be here if it weren't for me. But I think I got, at least as far as this goes, the better end, because it's really fun for me to be talking to students. Something about the wonder and the uncertainty of being a student, it's really fun for me to be around. So, thank you, Ellen. So, speaking of students, I wanted to talk to you about a study that I discovered recently. And this done by a researcher named Tim Anderson. And what he did was he gave a survey to graduate psychology students before they started their training. It's called the Facilitative Interpersonal Skills Inventory. And what these participants had to do was respond to, I think it was videotaped clients, theoretical clients in emotionally charged situations. And then what he did was he actually just put the survey results in the drawer and didn't look at them for several years. And what he found, well, any ideas what he found? He looked at, after these people had completed their studies and they were out in practicing clinical psychology. I'll spill the beans. The best predictor of the therapy outcomes of those participants was their score on this facilitative interpersonal skills inventory before they started their training. It appeared as if their training had nothing to do with how effective they were. Why? Why is that? How could that be? Well, you want to know what the facilitative skills were? There's some handouts here if you're interested, and this facilitative interpersonal skills survey is here, but these are the broad categories. Anybody try to work on these kind of skills? Okay. Maybe more on that later. So we have an inkling that training, whatever happens in psychology training, does not predict better therapy outcomes. What we've also found is that if you look at outcomes of students versus experienced clinicians, there's not a big difference. If you look at the outcomes of helpful lay people versus somebody who's actually had some training, the outcomes aren't a lot different. If we look at the treatment models that providers use, you've all heard of these, which is kind of the idea of the medical model where you target a specific treatment to a specific diagnosis. You have a streptococcal infection and you give Dr. Flynn, the infectious disease specialist, you give penicillin. Or you have a gallbladder problem and that needs to be removed. So it's a specific treatment targeted at a specific pathology. So that has not been shown to predict better therapy outcomes. Whether or not somebody was trained in 1983 versus today, and how people, the things that we look at to get into graduate school, which are test scores and grades, that hasn't been shown to be predictive of therapy outcomes. So you guessed it, none of these things actually show better outcomes. Am I making any sense? Amount of clinical supervision, how much continuing education, how much experience somebody has, what degree they have. So there is some good news. Talk therapy is effective. This was discovered in 1977. So you've probably heard of a type of study called meta-analysis, where you collect data from a broad range of studies and make conclusions. And the first meta-analysis was actually done on talk therapy, and it happened in 1977. And the idea of meta-analysis actually revolutionized health research. But what was found was that the average treated client, so the average person who was undergoing a course of psychotherapy, they were better off than 80% of people who weren't receiving treatment. It didn't matter whether it was an outpatient or inpatient, didn't matter whether it was adults or children, didn't matter whether it was individual or group. It was the same for people, subjects in randomized clinical trials, which carefully control their populations, or people who are in practice. When there's good news, unfortunately, there's some bad. Oh, I won't bore you with a lot of statistics, but I thought I might explain effect size. Would that be okay to do? So, you're familiar with a normal distribution, a bell curve. So if you think of this bell curve on the left as being an untreated sample, and the bell curve on the right as being the treated sample, when they say, so this is the average, these are the average clients in the treated sample, and they're better off than 80% of the untreated sample. That's a pretty big effect. That's bigger than most medical treatments. So the stuff that we do works. Talk therapy works. Bad news is it hasn't changed in 45 years. So this is, for those of you who don't know, Dr. Flynn knows what this is. This is a medical chart room. And so this is what has happened, probably in 20 years. A medical chart room has millions of charts are in that computer.
That was BC, before computers?
Yes, that's right. Good question.
Could you explain a little bit about the research that was behind this? Like what they sort of studied, like how did they determine this?
So how did they?
Measurables. What were the measurables?
So, that's a really good question. So, what they did, so let me see if I can explain it as succinctly as possible. Collecting outcomes in talk therapy is pretty rare. It's rare today. I'm going to advocate for people, who are here and listening to me to start collecting outcomes, but it's quite rare. There's been a number of surveys for many years that are available to assess. Basically, what you assess is client well-being. So there's different ways to do it, but you assess client well-being before they've had therapy. Most studies, what they do is they actually collect data at each visit. So if it's a course of outpatient therapy, they're collecting well-being data on the client at every visit.
And they have that from however many years back too? Mm-hmm.
And in 1977, they combined a number of studies and came to the conclusion, they have to make sure that they're comparing apples and apples. So they have to, there have to be, it's the idea of a randomized control trial where you have a randomized RCT, randomized controlled trials, where you have matched controls who go through some treatment, and then you have the treatment group, and you compare the outcomes. So the outcomes they're comparing, the measurables, is client well-being. Does that make sense? Stop it. So things haven't changed since 1977. So can you imagine this there's a few people in here who are around in 1977. Can you imagine this young guy having to have this guy tail him, harass him for another 45 years? Am I making sense? If my high school basketball coach had to be over my shoulder for the last 45 years, that's kind of like what's been happening in the world of talk therapy. Of course, I've not had him. I've improved. I don't need him anymore. Does that make sense? I'm getting some confused looks. I'm going to move on.
That is him.
So this is some other things what things looked like in 1977. Okay, so a couple of conclusions for you counselors. You may be close to as good a counselor right now as you'll ever be. And you may be close to as good as your teachers. And in the current and training and practice paradigm, you may not improve in your training and throughout your career. Or, if it's going to be very slight, if at all. So I don't know what I was hoping to do. I guess if there had been more people, I wanted to have you guys talk to a partner. I don't know if that's feasible in the setting that we're in. Maybe we have a conversation just among us as a group with this format. So the what is, things haven't really improved in counseling outcomes in 45 years. And so what? What are the implications of that? throw an idea out there. Maybe we're focused on the wrong things. Training's expensive. You guys are in school here, you're paying a lot of money for this. Talk to me.
Despite the training, because I know it seems like the educational programs are always bringing in new data, latest research, and there's always more and more research being done. So it seems to me that it would be changing a lot, but then if the outcomes haven't changed, then either it's not getting applied in the world, or with people being treated, or the world is changing just as fast, if not faster, than the research being done.
Yeah, so I'm going to just throw up this next slide. We can come back. So in the time since 1977, I think around 1975, there were like 100 therapy models. Now there's over 400. You know, we love to come up with new models. Everybody likes to have a new model. The DSM, I mean, just think about all the changes to that big monster tome. You know, all these subtle nuances of diagnosis. All of this stuff has happened, and yet outcomes haven't improved. Years ago, and there's some good aspects to this, talk therapy kind of married itself to medicine. You know, this specific treatment for a specific diagnosis. And, you know, that's largely now responsible for how people are paid, what insurance companies look at. And yet, quite frankly, that's just not how psychotherapy works. You know, when they do these things called dismantling studies, where they actually remove the specific nature of the therapy, and it still works. Talk therapy is more like the placebo effect than the medicine effect. It's not necessarily the placebo effect, but it's more like the placebo effect than the direct effect of it.
So just getting it as an effect versus like how it's delivered, or what you get, what's the specifics in session. Okay.
So we have ignored a very important factor. You know, with all our focus on diagnosis and models, can you guess what that factor is?
Yes.
Nope. You're close. There's two people. There's two really important people in that therapy room.
The patient, client.
You said the patient.
Relationship, connection, counselor.
You. There are these things called counselor effects or therapist effects. We've known about these for a long time. In 2007, a researcher named Scott Baldwin, what he did was he studied 330 clients and 80 clinicians. And they were measuring outcomes. And they rank ordered the clinicians in terms of effectiveness. And what they found was, and I have this study here, that the counselor's ability to form an alliance with the widest variety of clients predicted the outcomes almost one-to-one. It was almost to the point where you could take somebody who had a good alliance with a bad therapist, and somebody who had a bad alliance with a good therapist, and the person with the bad alliance would still most likely do better than the person with the good alliance because of the therapist.
Okay. So then it really matters how good the therapist is.
It really matters the effectiveness of the therapist. When they first started studying outcomes of psychotherapy, they treated therapists, counselors, as a fixed factor. And it confounded their data until they kind of scratched their head and say, well, maybe there are therapists. And they discovered that there's a wide variety, a wide variance in the effectiveness of therapists. So this is the stuff that gets very tricky statistically. But counselor effects are account for 5 to 9% of the variance in outcomes, which is 5 to 9 times more than the variance accounted for by the treatment model that somebody uses.
I was going to say, I actually got shivers down my spine when you put that picture up of the old medical charts. I do remember those days, that's for sure. I think the biggest thing, really that kind of changed the whole landscape was, when we went to almost an exclusive sort of medical model for reimbursement. I'm old enough to remember we used to get an allocation of grant funds, and we could spend clinical hours. We could see a patient for an hour, sometimes an hour and a half. We don't have that luxury anymore. We've been doing the equivalent of therapeutic speed dating for quite a while now, and it's of concern to me, and I'm still practicing a couple of days a week in conjunction with doing some supervision, but I'm obligated to see 14 patients in a day. One hour admin and then 14 patients. Now, we have a very high no-show rate with the folks that we serve in primary care. So we're looking at probably around at least a 20%, sometimes as high as 40% no-show rate, even with the advent of telehealth, where you can just kind of shoot a Zoom link to it and you can. But that's really the biggest change that I've seen evolutionary from when I was providing services back in 1975. I can even say that.
Well, and I think too, I don't have a lot of data on this, but I think that reimbursement rates and incomes have probably gone down, and prescription rates, antidepressants and psychopharmacology has skyrocketed, while talk therapy rates have gone way down. Right? So it's I don't have a good answer, but it might be time for a divorce.
It's going to take like a major overhaul, CMS. That's really going to be what the bottom line is going to be too. I think if they went back to an old allocation where you just give primary care centers, just give them X amount of dollars. You go ahead and see these patients. Though you're not going to be sending in a billing to Medi-Cal, you're not going to be sending in a billing to Medicare. You're not going to be eating it because it's self-pay. I don't know, but things move so slowly with American healthcare. Look at the Patient Protection Affordable Care Act. I've been in the United States since '84, and I can tell you, I couldn't believe that people could not get health care when I first moved down here. It was amazing to me. It was all tied if you were employed, which is the perfect Republican model for it. But I don't know if you're ever going to see that change. But it definitely changed the landscape for the number of people that we can see. And I know we're doing a significant benefit with the advent,
All right.
of that act. That's my little speech today.
Thank you. glad to have you. Thank you. So, so what's the problem? What's the problem with training programs? Well, my theory is that you don't know crap. Whoa. Pretty bold statement. Wait for it. And I think that's a good thing. So let me explain. So I wouldn't expect to come up here and bash training programs and be expected to be invited back here. Although I was in the big conference room last year, and now I'm here, so I don't know. Next year I'll be in the parking lot. But so training programs are certainly useful. There's definitely useful skills that get learned. There, especially the empathy and listening skills. There's helpful. You need to learn methods. The only way to organize therapy is around methods. So you can't just go in there and wing it. You need a method. We get to practice before we're independent. We get to watch other people practice. We join a group where we learn together. So training is useful. I wanted to talk a little bit about this beginner's mind idea, because this is a concept from Zen Buddhism, and it refers to having an attitude of openness, eagerness, and a lack of preconceived notions when studying a subject, even when studying it at an advanced level. So I love this quote: "In the beginner's mind, there are many possibilities. In the expert's mind, there are few." So this is a very critical slide. This is what I believe you guys are doing now as students. You're asking these questions. I want to be helpful. I went into this program, I went into counseling and therapy to be helpful. I enjoy that. I need to be able to do that. It sounds maybe a little bit adolescent, but how do I get my clients to like me? Clients are crying, angry, and sobbing. They get emotional in therapy. How do I respond to that? They say you're not supposed to give advice. What do you do if they ask for it? Because they do. I make mistakes on a weekly basis, probably on a daily basis, in just my interpersonal communication. I'm aware of some of those, because as soon as I say it, I said, oh, I shouldn't have said that. But what about the ones I'm not aware of? And how do I find out? Like I said, there's two people in the therapy room, and the most important person is the client. How do I get feedback from my client? How do I find out how they feel? I think about my clients all the time. I think about them when I'm eating dinner. I think about them when I'm watching TV. I think about them when I go to bed at night. I think about them when I wake up. What can I do outside of my sessions to improve what's happening when I'm in my sessions? I get very stressed out sometimes with clients. I know they're going to be angry. I know they're going to be upset. How do I work with my own feelings with my clients? I don't want to bother my supervisors. I want to have a good relationship with my supervisor. How do I work with them without asking too many questions? Anybody relate to these kind of thoughts?
That's where mentorships are so important. When somebody comes in to do an internship, or they come on board maybe as a green LCS or ASW, say for instance, just got their degree. What they're going to learn, what they've learned in theory is very going to be applicable to what they're doing. But then there's the reality of insurance coverage and all this other stuff. But just learning and being able to have somebody that can walk them through. I know I had a psychiatrist just sit me down and he said, yeah, let me tell you how it works. Boom. Spend at least a couple hours with me. And that 2 hours was probably as beneficial as one of the years of the undergrad or the grad program.
So, what happens with experience? Watching. I think those those questions kind of fade into the background. One thing does improve with experience. Can you guess? Can you guess? Yeah.
Getting questions from your client? I mean, getting.
And what improves with experience? What do you have developed more of?
Rapport with your client.
Confidence?
Yep. She's a ringer. So confidence, I mean, it comes with familiarity and repetition. I mean, it's human nature. It's what our brains do. Our brains have to be very efficient. If we're more familiar and we repeat something, we don't have to devote as many resources with it. It leads to something that's called automaticity, where you really don't have to think about each step in a process. The problem is that automatic behavior can be very hard to notice because you're almost unconscious when it's happening. And repeating patterns can go on for years, in fact, maybe even a whole career. And so what's the antidote to automaticity? Well, that's what I kind of wanted to talk about. Well, I did want to mention two. So there's the traditional paradigm, and then I put FIT up there, feedback informed treatment. So it's normal to kind of overestimate our effectiveness and be biased towards our successes. So, for example, here in this talk today, I am 100% responsible for keeping you engaged. If I'm looking out and I'm seeing some yawns and people looking at their watches or their phones, I might think, oh, it's Friday almost noon, thinking about what you're going to do this weekend, trying to get to your homework or whatever you got to do. But if I see people engaged and responding, I'm thinking I must be doing a really good job. So it's normal to kind of, quite honestly, blame our clients when things don't go well and give ourselves the credit when things are going well. So this is the key difference, is that the provider is not responsible for the change that has to happen in the client, but they are responsible for the engagement. So let's talk about feedback, since that's kind of the title of the talk. The definition of feedback is, I just found this little definition: information about reactions to a product, a person's performance of a task, etc., which is used as a basis for improvement. So that's the critical idea, is used as a basis for improvement. So maybe since we're a small group, I'd like somebody to volunteer to think of a time when you wanted to give feedback about something, but you didn't. Anybody have?
I think our first year, a lot of us didn't give feedback because we were so unsure of everything going on. We started during the middle of the pandemic, so we were on Zoom, so we didn't actually know our professors. So asking or providing feedback was difficult. And so I think that it might have slowed down development in some ways.
So can you maybe say a little bit more about why? So you're talking about giving feedback to your professors about?
Well, because we weren't in person with them, so we didn't know them. So you don't know how they're going to respond, what their temperament is. A lot of the time, most of them were pretty cranky because we all had Zoom eyes. We all had Zoom headaches. So you didn't know how to gauge how they were going to react. We could, and some students did, step forward and say, hey, I'm feeling some kind of way about this, and the professor might have gotten a little upset. Whereas another professor might have not. We decided there were no predictors. There was none of the body cues we're used to seeing.
But there were probably some things that were going on. Some of the professors, you thought they may not really be open to the feedback.
Sometimes.
Okay. Okay. Anybody? Any other thoughts? Mandy?
I was genuinely fearful of what the outcome would be if I did share what my experience was. Thought there might be some kind of backlash or it would come back on me.
Was there a specific time when that?
Yeah, and I had an appointment with an OB, poorly treated.
Okay.
So it was uncomfortable all around.
And you didn't want to give feedback because you...
For one, I didn't want to really relive that situation. I was so upset.
You didn't think the person would be open to it. You thought you might get
And
some,
yeah, it seemed
some
like it was sort of a systematic
defensiveness
problem.
or...
It was- Yeah.
Okay.
Yeah.
Okay. All right. So how about this? How about another time when you were hesitant, but the person you wanted to provide feedback for? I'm gonna give an example, but I'd like to hear from you too afterwards. So many years ago, I did do addiction medicine, and I was called to evaluate a healthcare professional. It was a woman who was, I can't remember, with EMT or some kind of job like that. And she had a couple of incidences with alcohol that were quite serious. And she was giving me her history, and she was pretty well minimizing the events and minimizing the amount that she drank. But the events were really serious. And she was paying me to do this evaluation. And, I got all nervous and anxious because I'm thinking this person has a serious problem. And at some level, I just said, thank you for sharing that. I think you have a serious problem with alcohol, because she had been totally minimizing, and a little single tear came down her face. And she said, I know. And I could have easily just glossed that over, kind of taken what she had said at face value, but I didn't. Anybody else? Anybody having a feedback?
Why? I recently took over a practice that was new completely to me in the type of medicine, specialty that was being treated. But I did notice a lot of things were not done to its norm that I was comfortable with in healthcare. It was hard for me to give my feedback because I'd never practiced in this specialty before. But I was able enough to evaluate what was going on and knew I had the supporting staff that said, here, whatever you see wrong, fix it. And then you see it wrong, don't even ask me, just fix it. So that made it possible for me to go in and make the changes and then collaborate and learn a lot more along the way as I made those changes.
I'd like to think that there was something about that organization that made you feel like they were open to feedback.
Right. I mean, I had a good medical director stepping down, and I had a new medical director that will give it to you like it is, and then still smile and be so calm with it, like, yeah, I don't care. Makes sense, do it. He's actually presenting for y'all today.
So, thank you for that. So, talk a little bit about this method that has me so intrigued. Starting in the late 1990s, it became more common to measure outcomes. The specific measure is not so important. This is a great way to address health equity issues and provide culturally responsive care. think of it as, you know, the traditional, certainly the traditional medical world, but probably the traditional therapy world is kind of hierarchical, where the provider is above the client. This is a way of amplifying the client's voice, kind of leveling the playing field. As mentioned, the client, of course, is always responsible for the change, but the provider is responsible for the engagement. And this is a fairly unique concept. You know, it's not unusual to survey clients about how they're doing, but it's pretty radical to actually ask them about, you know, how are we doing? So there's no question that routine outcome monitoring can improve outcomes, decrease the number of people who drop out or deteriorate, shorten length of stay, reduce cost. And this is, I think, a pretty critical idea. It's a very satisfying way to practice. And so there's reduced burnout. I'm just going to talk about that a little bit. The work that we do is difficult. You know, people are suffering and struggling. When you feel that you're effective at something, it gives you great satisfaction. And it appears as if the best therapists actually experience low levels of burnout. And what we believe is that the reason is that the best performers are attentive to outcome rather than what we term healing involvement. So feedback-informed treatment is very, very attentive to outcome. And therapists who burn out actually are more, they rate healing involvement higher than outcome.
Wait, what's the difference between healing involvement and outcome?
I was hoping I wouldn't get this question.
I'm sorry. You can keep going.
No. I mean, it's, have you ever, have you ever found yourself getting really attached to a client?
Yes.
And have you ever gotten home at night and just thought, you know, that was a really good session. I was on top of the world in that session.
I haven't been a counselor yet, but with the job that I worked before I came to this program, yeah, I've had that.
That's healing involvement.
Oh, so like the self-grandizing, like, oh, I did so good, I'm so great.
Kind of. Yeah, I mean, it's human nature.
Right.
Don't get me wrong, and I don't. But it appears as if, and there's actually a study that I just found this morning that I want to dig into. Mm-hmm. But therapists, and I don't want to say top performers don't ever get involved with their clients in that way, mm-hmm. but it's really the highest level is outcome.
Okay.
Make sense?
Yeah, I've had that in my previous job. I felt the difference between, oh wow, I did so good versus they did so good, I'm glad I could help them.
We have a comment that I've followed a number of patients for 10, 20 years, and something that seemed futile to me in the beginning, as they go along, if you can just slow down your expectations as they go along, and 10 years from now, they may have changed quite a bit, where in the little increments that we see from week to week or month to month, they don't. But you look back at when they came and where they are now, it's very different.
Okay.
They ask me much more insightful questions. How do you do that?
So for the last 2 days, so yesterday and the day before, I attended an online training on feedback-informed treatment implementation. And much of the conference was about how to sell the method to stakeholders who were steeped in a different way of doing things. And The data is that it takes a long time practicing feedback-informed treatment to where you can actually see outcomes get better. 3 to 7 years. And those are the ones that are successful. There's quite a few that aren't successful. And so I was just scratching my head thinking, you know, how would it be as a student to learn this method from the beginning? So you could avoid this pain of having to learn it later. Does that make sense? So you got less to unlearn. So I know we're coming up on the end here pretty soon. How do we use outcome monitoring? Well, it's a great way to set parameters in therapy from the start. Basically, you say, I work a little differently from most counselors. I collect data at the beginning and the end. And so, you know, this isn't, you know, Dr. Flynn's comments notwithstanding, this doesn't have to take years for you to get better. If what I know is gonna help you, we should see some improvement within weeks. And if we're not, then I need to do some adjustment to figure out how to help you better. And in an extreme case, you know, I don't help everybody. I may not know exactly what you need. So in an extreme case, we might need to get you to somebody else or some other place. So that's how you kind of introduce the measure from the start. It's incredible in the way that it helps improve responsiveness. I don't know if you remember all the way back to that facilitative skill list, but number 8 was alliance rupture and repair responsiveness. So really, you know, like I said, we make mistakes every day. And, you know, a lot of them, we don't even know we're doing it. So collecting outcome data, collecting data from your client is a great way. So I don't think, you know, this is probably more advanced deliberate practice, but collecting feedback, collecting outcome data is a great way to improve your effectiveness, you know, one client at a time. And
At a certain time in, say, a clinic, that it would be more effective to implement this monitoring? Like, what if the clinic's in transition? Would it be good to wait after that transition?
so you,
Does it matter?
no, I mean, you have to start with new clients. You can't bring clients in the middle of it. Because, well, let me show you, so this is a very simple scale that we use, that I use. It's called the outcome rating scale. I think I can get to your question. But this is the scale that you give them at the beginning. This is a 10-centimeter line. They're electronic databases. They cost money, but people can do it on the phone or their computer. They lower scores here, higher scores here. They make a mark. You measure it with your ruler. This is 10 centimeters. You add up the score. You get a total score on the ORS. It's very simple. It takes less than a minute. Given at the beginning, basically you measure either in the past week or since their last visit, including today. It checks all the statistical boxes. It's very simple, but it's quite powerful. Then the relationship scale is this one. Same idea, a little bit more self-explanatory. I felt heard, understood, and respected. I did not feel. We worked on what I wanted to work on. The therapist's approach is a good fit, or it's not. And then overall, something was missing. It felt right. Again, a minute or less.
Just really quickly, in thinking about my own therapy, I sometimes find at the end of the session, and like, we haven't even talked about what I wanted to talk about, and this would be so helpful, and like, I don't know how to give that feedback, but like, you have to think about your own therapy too.
Well,
in this,
do you,
and that's helpful.
I mean, I'm just going to throw this out there.
Yeah.
You know, if your therapist is creating a culture of feedback, then you feel empowered to do that.
Exactly.
So what I was going to show you, though, is this is a graph. So, you know, as a doctor, I have my stethoscope, I have my lab tests. This is a graph of a theoretical client on an electronic database. This is their outcome scale, this is their session scale. And you got a red, green, red, yellow, green, right? If they're in the green, they're on track for a good outcome. You know, is it 100% certain they're going to have a good outcome? No, but they're on track. If they're in the red, they're not on track, and you know it, and it can start the conversation. Does that make sense? Okay. So feedback is crucial to improve. I mean, the only way you know how to get better at anything is if you get feedback at how you're doing, right? It's crucial to developing expertise. It's a skill. So the most effective therapists are able to get the most amount of negative feedback. So what that means is, you know, I don't honor my mistakes. I don't like making mistakes, but I know that I'm going to make them. And if I can know about them quickly and adjust, that is so good for a relationship. So that's getting negative feedback and acknowledging, responding to it is very good for a relationship. I was going to do a demonstration, but don't really have time. But I kind of talked about it when I introduced the outcome scale. And so what I've learned in using this method is that if you're open to feedback, you'll definitely get it. And some of it will be negative. Most of the time, though, it's not a big thing. It's not cutting and biting. Most of the time, it's something small. Clients are quite surprised when you ask. It's a big culture shift for both the client and the provider. Feedback definitely improves responsiveness. You've got to learn to sit on your hands. If you do get negative feedback, you can't respond defensively. But responding to feedback, especially negative feedback, strengthens the relationship. It's much better as a team. There is such a thing as fit supervision. Feedback can guide your therapy. So, as a student with beginner's mind, you have a gift. Enjoy it now because you may soon lose it. Curiosity that you have now gives way to confidence. Curiosity is important for multicultural competence. Curiosity keeps the automaticity at bay. You can start your career using this, and it would be really great to have this become automatic. I believe eventually, over years, this is the way therapy will be done. Your clients can help you be responsive and quickly correct your errors. And practitioners who pay attention to feedback help 50% more clients. So start thinking about ways to develop a culture of feedback. I have copies of the measures. You're welcome to take them. You can download them from this website. Ask your supervisors if they're open to using feedback measures. Those facilitative skills I have listed that they're in these handouts as well. Rather than specific model and diagnostic skills, find some colleagues that are interested. Stay curious and open. And that's me.
Would we be able to get copies of that PowerPoint?
Yeah, I'd be happy to.
Okay, I'll give you my card.
I'd be happy to email.
I can see the real benefit to this. I supervise instruments.
I'd love to.
Licensed
Where do you supervise?
well space.
Oh, Allspace. Okay.
I'm working
I'm a little recruited.
I'm working at Turning Point, so I get a lot of your well space referrals over there.
Yeah. I've had a stint with Telecare too, so.
And I'm more than happy to present to you know,
Oh, man, I'd love to bring you in.
for free. I'm,
Yeah.
so thank you for your attention.
You guys want to finish as well? I'm sorry, that's what I meant. We have a special
I'm gonna airdrop this one to you.
It's that red.